Welcome to today's explainer. Look, if you're trying to completely master the upper limb without getting totally lost in the details, you are in the perfect place. तो चलिए शुरू करते हैं. Let's get started. Today, we're taking a really deep dive into the anatomy of the pectoral region, the back, and the axilla. We're going to break down all these complex structures so they just instantly click in your brain.
But hey, before we jump into the heavy lifting, I've got a quick question for you. Think about the rotator cuff for a second. Do you know which specific muscle is clinically known as the forgotten muscle? Just keep that in the back of your mind. We're going to decode the answer together very soon. Let's dive in.
So here is our roadmap for today. 1. Bones, scapula and humerus. 2. Pectoral region and winging. 3. Back and the rotator cuff. 4. Shoulder abduction. 5. Shoulder spaces. And finally 6. Axillary boundaries. All right, section 1. Bones, scapula, and humerus. Time to lay down the foundation.
You know what I always tell my students, right? Base strong hona chahiye. Let's build that rock-solid foundation by looking at the anterior and posterior views of the scapula. Notice these major landmarks acting as massive anchors. See the coracoid process projecting anteriorly? This right here is the anchor point for the pectoralis minor, the coracobrachialis, and the short head of the biceps. Then, look over at the acromion and the spine on the posterior view. These serve as the massive origin site for the deltoid and the insertion for the trapezius. Now listen up, because here is a massive shortcut. Ratta nahi marna hai. Please, do not just blindly memorize this stuff. There are simple, logical rules for scapular attachments. Generally speaking, the lateral borders, those are for muscle origins. The medial borders, those are for muscle insertions, like the serratus anterior and the rhomboids. And the fossas, the supraspinous, infraspinous, and subscapular fossas, those are all origins for your rotator cuff muscles. Master this pattern, and you've literally won half the battle.
Okay, next, let's slide over to the upper end of the humerus. Right at the top, sitting between the greater and lesser tubercles, you've got the intertubercular sulcus, which is also known as the bicipital groove. This specific little groove is incredibly high yield for your exams.
And you guys already know what's coming, right? This brings up one of my absolute favorite classic mnemonics, lady between two majors. Let's break it down. The pectoralis major inserts on the lateral lip. The teres major inserts on the medial lip. And sitting right there in the floor of the groove is the latissimus dorsi, our lady. Lateral major, medial major, lady right in the middle. Perfect.
Section 2. Pectoral muscles and winging. Let's look at some muscles and clinical signs.
Excellent. So the foundation is set. Now let's pack some muscle onto it. We have our heavy hitters right here. Pectoralis major, pulling the arm in for adduction and medial rotation. Just beneath it, the pectoralis minor, grabbing onto that coracoid process. But hey, I want you to heavily star this last row, the serratus anterior. It originates from the upper 8 ribs and inserts right on the medial border of the scapula. And its nerve supply? The long thoracic nerve. Ye bahut important hai. Mark my words, this is a very, very important nerve for exams. Why is it so important? Well, because of this exact clinical presentation. Imagine a patient comes in and their scapula is protruding backwards like a small wing. This is the classic winging of the scapula. It happens when there is an injury to that long thoracic nerve, which is also beautifully called the nerve of Bell. When this nerve gets injured, the serratus anterior gets completely paralyzed. This leads to the unopposed action of the retractors of the scapula, pulling the medial border right away from the thoracic wall. Samajh aa gaya? It's a very classic clinical case. Before we leave the pectoral region, let's quickly nail down a direct factual question. The structures piercing the clavipectoral fascia. This is the fascia lying right between the clavicle and the pectoralis minor. Just remember these 3 key structures that punch right through it. Number 1, the thoracoacromial artery. Number 2, the lateral pectoral nerve. And number 3, the cephalic vein. Just memorize this quick list, it's a super common exam target.
Moving on to section 3. Back muscles and rotator cuff.
All right, let's flip our virtual patient over. Here's the breakdown of your massive superficial back and shoulder drivers. The trapezius originating all the way up at the occipital protuberance, inserting on the scapular spine, responsible for elevation and overhead abduction. Then you have the latissimus dorsi sweeping up from the lower back to insert into the floor of that bicipital groove we just talked about. And capping the whole shoulder is the deltoid, driving abduction from 15 to 90 degrees. Guys, these muscles control the massive macro movements of your upper limb.
But what about stability, right? That brings us perfectly back to our hook from the beginning, the rotator cuff, easily remembered by the acronym SITS.
supraspinatus, infraspinatus, teres minor. And the answer to our question, subscapularis. It's called the forgotten muscle because it sits deep anteriorly in the subscapular fossa. It's completely hidden from the back. Localization of pathology here is notoriously difficult compared to the other three. But together, this entire cuff is what actually keeps your shoulder joint stable.
Section 4. Shoulder abduction. Let's look at these dynamic movement phases.
Now that we know the muscles, let's put them to work and look at a really dynamic physiological process, shoulder abduction. How exactly do you lift your arm up? Well, abduction is not a one-muscle job. It's like a beautifully coordinated relay race. You can see the supraspinatus sitting on top, the massive deltoid wrapping around laterally, and the trapezius superiorly. They essentially pass the baton to one another to achieve a full 180 degrees of movement.
So the absolutely crucial point here is knowing exactly who drives which phase. Step 1. From 0 to 15 degrees, the movement is initiated by the supraspinatus. Step 2. From 15 to 90 degrees, the heavy lifting is taken over by the middle fibers of the deltoid. And Step 3. From 90 to 180 degrees, for full overhead abduction, the scapula itself actually has to rotate, and that is driven by the trapezius and the serratus anterior. These degrees and their corresponding muscles, super high-yield concepts.
Section 5. Shoulder spaces, the neurovascular highways.
Excellent. Let's shift gears from the muscles themselves to the architectural gaps left between them. Notice how the teres minor on top, the teres major below, and the long head of the triceps vertically dissecting them, they beautifully create these specific little windows. We have the quadrangular space laterally, the triangular space medially, and the triangular interval dropping down inferiorly. You absolutely have to know what travels through these highways. In the quadrangular space, you have the axillary nerve and posterior circumflex humeral vessels. Listen, this is a major danger zone for surgical neck humerus fractures. Down in the triangular interval, you have the mighty radial nerve alongside the profunda brachiate artery. And finally, in the triangular space, the circumflex scapular artery. Keep this breakdown handy for quick revisions.
Section 6. Boundaries of the axilla, the ultimate gateway to the arm.
Finally, our last anatomical region for today, the grand gateway from your neck straight down to your upper limb. I want you to mentally trace this 3D pyramid shape. The axilla isn't just an armpit, guys. It's a geometric space. The apex is the cervico-axillary canal right at the top near the clavicle and first rib. The base is the skin, and it has 4 distinct walls, anterior formed by the pectoral muscles, posterior formed by the subscapularis and lats, medial formed by the serratus anterior and ribs, and a very narrow lateral border right at the bicipital groove.
And what exactly is safely packed inside this pyramid? Well, a whole lot of fat, for one, to protect all the vital structures. But essentially, it holds the axillary artery and vein, the cords of the brachial plexus, and the axillary lymph nodes, which are incredibly vital in breast cancer metastasis via the tail of Spence. And bringing our entire lesson full circle today, remember that nerve that causes winging of the scapula? The long thoracic nerve travels straight down along the medial wall of this axilla. See, it is all connected.
Okay, let me leave you with a quick clinical challenge to test what we've just learned. If a patient comes into your clinic and absolutely cannot initiate the very first 15 degrees of shoulder abduction, which specific rotator cuff muscle, and by extension its nerve, are likely compromised? Think back to our abduction phases. Yep, you nailed it. It's the supraspinatus muscle supplied by the suprascapular nerve. Keep revising and keep visualizing the anatomy in 3D. Anatomy is all about logic. Partereye, machatereye.